Good morning.
Good morning. Oops. Hoping you're well.
I am.
That makes me happy. So, welcome to you, welcome to me, and welcome to yeah, hello, ladies and gentlemen that will be coming up. We always love that. Have our questions and we can get started. Are you ready for me?
I am.
Okay. So, Dr. Rosensweet, first question comes in from a lovely woman stating, I was on excuse me, I was on HRT for 20 years, and at the advice of my doctor, I was slowly able to wean off of these hormones, but now I am miserable. My hot flashes are back. I'm 65 years old. I am not sleeping well at all, and I would very much like to go back on hormones, but due to my age and what I've been told, it's really a bit scary. So I was wondering if maybe I could have your thoughts on this, and thank you.
Yes, and this is such an important question because, with all due respect to a probably very caring physician, this is the absolute opposite of what the science is and always has been about taking hormones. No one ever thought beyond prior to 2002 that women should stop taking the hormones, and most women didn't think of stopping taking the hormones. It wasn't an issue. And in 2002, there was a scientific report called the Women's Health Initiative that reported false, I'm lingering on that word, false findings. What they reported was false. And they did it under great controversy, and the report was published against the wishes of many on the subcommittee because they published that there was an increased risk for breast cancer, heart attack, and stroke, but their data did not show that. There was reduced risk with the main hormone that was studied, Premarin, estrogens derived from pregnant mares, Premarin, with reduced risk. Women who were on Premarin had less risk for breast cancer, heart attack, and stroke than women who were not on Premarin. There was a statistically insignificant risk, 1.26 relative risk, that's statistically insignificant, with Prempro, that is Premarin combined with a progestin. There were so many faults in the study, but even in the report itself, it says the risk was statistically insignificant. In science, that means there is no risk, plus or minus. But the press did not pick up on that. All the press picked up on was increased risk. It spread like wildfire. It scared women all over the world who were on Premarin. It scared women all over the United States who were on Premarin and Prempro. And it scared the physicians and nurse practitioners that were prescribing these. All that they read was increased risk, even though that the study did not say that. The study said it was statistically insignificant. But, there was 40% of American women in menopause on Premarin and Prempro in 2002, and that reduced to 4%. Wow. There was 18 million American women protected and supported by Premarin and Prempro. And it went down to 4 million. And it was just a tragedy because the consequences of those women stopping those hormones were dire for so many of them. They lost bone, they lost vagina, they lost cognition, they lost so much. And there's medical studies reporting the increased number of deaths that occurred and the increased consequences. There's medical studies that report that from the stoppage of these women stopping their hormones. Well, the study continued in the sense that these women were all followed up, and by 2006, the relative risk that was statistically insignificant of 1.26 reduced to 1. I saw that happen. many of my colleagues. But I knew the 1.26 was statistically insignificant. And finally, the original Women's Health Initiative Study Committee that published the false information got out there in 2017 published another article saying that after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke.
But did people believe that?
Well, nobody heard about it. There's so few people. The press didn't take that retraction and just blast it all over the planet Earth. And I have a contact, because of what I do, with a lot of physicians and nurse practitioners. And it's so unusual to hear of anyone who's heard of that study retraction. Well, myself and many colleagues right out of the gate saw the falseness of the report, read the European literature on the safety of the compounded bioidentical hormones. I had already been prescribing compounded bioidentical hormones for 10 years at that time. And we just continued on. And also significant, by 2016, there had been some recovery of women being treated. It got up to 6 million American women were being treated, and over half of those women were being treated with compounded bioidentical hormones. Here's what we teach our healthcare providers. Get a woman on hormones who wants them as early as you can, and for their whole life. Oh, talk to me. Am I going to stop my testosterone? No way am I going to stop it. This will be with me until the last breath. Why? And men got scared, and urologists got scared about testosterone when the opposite is true. And prostate cancer was based on false information. Same thing happened to men. So it's not like we're not at risk for cancer. We're at risk for thousands of diagnoses, and a lot of those diagnoses are not good. They're rough. And we're all at risk of cancer, hundreds of cancers. And as a man, I have special risk for prostate cancer, and there's reasons why that's so. And women have an increased risk for breast cancer, and there's reasons why that's so. However, here's the science, as it is so excellently unveiled in a book called Estrogen Matters by Avram Blooming, MD. He's an oncologist who specializes in breast cancer, and Carol Tavris, PhD. Carolyn, would you post the link to that?
I sure will again. Yeah, it goes so fast down that, I keep posting it, but it's making its way.
For those of you who want to get the details of what I'm about to say, that though we're all at risk for cancer, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke, less risk than women who are not treated with hormones. That's the science. So your physician, who may just have been wonderful in so many ways, there's very few physicians and nurse practitioners who have specialized in this. And then the information is just not out there. And there's so many functioning, they got scared. They don't want to hurt anybody. They got scared in 2002, and that information, that false information, got just exploded out onto the world. So many people know this one, but the retraction has not. But you could buy that book for your physician. But here's the bottom line. We suggest that when women are coming to the realization that they want to be treated with hormones, whenever that is. I started treating my mom when she was 86. Whenever that is, go on them and get them adjusted really well, fine-tuned, and stay on them for every day that you're on Earth. Don't miss a day. Now, it's not going to be that big of a deal. It's not like missing a blood pressure medicine. You don't want to miss blood pressure medicines. You can miss hormones, but go back on them. That's my best advice. And if you have any concern, read Estrogen Matters that Carolyn's going to post.
I got
And
it. I got
so
also.
your doctor may not, you could buy a copy for your doctor of Estrogen Matters. It's lengthy and it's a wonderful scientific document. And if your doctor doesn't feel comfortable, there are providers that do, and you can contact us, contact Carol, she'll know where to send. At least we'll see if we have one of our providers. But there's a lot of folks there's a lot of healthcare providers, physicians and nurse practitioners who are aware of this revelation about no risk. There's many physicians and nurse practitioners were aware that it was wrong in the beginning. I certainly have many colleagues that looked at that and went, they're blowing this up and it's statistically insignificant? Come on now. And that was Premarin and Prempro. That's not compounded bioidenticals. But listen, if Premarin and Prempro have done a lot of good on this earth. So anyway, 68-year-old woman, I'm trying to do a about face with you, help you get back on those hormones and take them for the whole rest of your life. It'll protect your bones, your vagina, your mood, your libido, your muscles, your brain, your coronary arteries. These hormones are so beneficial.
Virtually everything.
Yeah, virtually everything.
Yeah, she was very frightened, and I would think that her doctor said, maybe we can put you on these for a little bit, but then we got to take you off. It's a story I've heard a lot, and thank you for clarifying that. Very, very much appreciated. So, moving on. Good morning, Antoinette. Good. Moving on to question number 2. So, is estrogen safe, Dr. Rosensweet, to take after endometrial cancer and a full hysterectomy, meaning oophorectomy and ovaries removed as well?
Yes. Next question. Okay,
Let me answer that one.
I'll elaborate. Cancer is not caused by hormones. This is very important to understand that. Young men, young women have very robust levels of hormones, and they do not cause cancer. Now, there are causes to cancer. Yes, sir. There's thousands of them. Health adverse choices of what you eat, what you breathe, whether you exercise or not, and how you handle the stress of life. And then there's some mysterious causes, but it's not hormones causing cancer. Now, not only that, you don't have an endometrium, you don't have a uterus. You are safe to walk about the cabin with your hormones. End of story.
In hand.
Even if the possibility is that you had a metastasis, that means some of the cancer went to another part of your body. It is very uncertain whether taking hormones would even make that grow. That can grow, but that'll grow on its own. The cancer part of it is the part that's unresponsive, and it doesn't matter if you take hormones or not. I know it's a very mixed question about even if it had estrogen receptor sites, but this is very rare. If that endometrial cancer was caught early, that hysterectomy is usually 100% cure. If it was advanced, if that endometrial cancer was caught at a very advanced stage, you are going to need to consult with your oncologist. But endometrial cancers usually show themselves pretty early with abnormal bleeding before there's spread at all. So, and the hysterectomy in those cases is 100% cure. End. Now, you do want to clean up your health story because you did get cancer, and you want to just work on your nutrition and get it cleaner, and work on what you breathe and what you apply to your body and what kind of household toxins you might have, like cleaning fluids and stuff. You've got a journey to do to improve your health. But unless you had a very advanced cancer, you're free to take those estrogens, absolutely. And there's consequences of not taking hormones.
That's a thing. Yeah.
That, women who don't have hormones, they're at risk for coronary artery, arteriosclerosis, heart attack, bone loss, almost certain to happen, osteopenia, osteoporosis, fracture, muscle loss if you're not taking testosterone, vagina loss. Yeah, that vagina can get so atrophied that you can hurt, and you can start getting more bladder infections. Cognitive decline. There's huge consequences of not taking hormones for most women. And there's huge consequences of men not taking hormones. We're living a lot longer these days, and we still lose the majority of these hormones at midlife. And we have the opportunity to replenish them with the same molecule that the ovaries were producing. Go for it.
Absolutely. Yeah. A lot of people don't know, and so well, that's why we're here to help let them know. Um, you've often said many times that these hormones are the most important biochemicals that we have in our body. Correct? Yeah. We lose them, we feel it. Replace them, we feel it. It's a good thing. Thank you, Dr. Rosensweet. Question number 3 comes in. Is it possible for the creams or oils to just not work for someone? And if this be the case, why would this be?
28 years of working with women, I've never seen creams or oils or gels not work. And now I've had dropouts, women who were working with me, and they disappeared. So I don't know, but I can tell you that hormones have a complexity to them. And the deeper you study how female hormones work in your body, the more awestruck you will be.
Yes.
It is the symphony and the balance and the individuality and the individual balance between the different hormones. It's quite an art. Get it right. And that's what you need. That's the main thing you need. So I'm going to raise the possibility that there's who was ever treating you didn't have the knowledge and experience to dig in and really try and figure out what was going on. Because there's possibility of underdose, there's possibility of overdose, there's possibility of individual imbalance. A doctor was reporting yesterday in Grand Rounds that she herself took too much progesterone and started getting hot flashes. And there's technical reasons why that happens. If you don't get these hormones balanced in the right and individualized for your body, that's our main emphasis. And we spend quite a time in the first year doing this with patients in the menopause method. We spend anywhere from 4 hours over the first year to 16 hours over the first year. Over many consultations, just dialing it in and tweaking this and tweaking that and eventually confirming by testing. It's not a problem. I'm not talking about a problem. It's just a process that anyone who has been properly trained will go on the journey with you. But why am I mentioning that amount of time? Because to get your hormone dosages and ways of delivering it optimal, it's a piece of work. No problem for someone who's been trained and experienced. It's fun. But I'm going to suggest that it may not be it's probably not the creams and gels and oils that is giving you the trouble. It's probably dosage issues and where you're applying them. And that's so your job becomes what every woman's job is. This is your main job. This is it. If there's anything that I would like anyone to walk away with from our Facebook Live, there's one thing is that you take on the project of finding a healthcare provider, a physician, nurse practitioner, in some states a compounding pharmacist or a PA that really cares about treating women in menopause with compounded bioidentical hormones and has gotten significant education, not just a weekend. No way. And has got significant experience and loves the work, in his best case, specializing in it. So that's your job. And you have to go shopping because, unlike neurologists and orthopedic surgeons and gynecologists who have specialized in their specialty, there are very, very few providers who have specialized in treating women in menopause. Very few. So you got to go shopping, but they're out there. And there's enough. And that's your job. And you may have to go shopping. You may have to interview office managers and ask them a few questions to feel if you're comfortable, because here's what you want. You want someone who really cares and is doing this as a major part of what they're doing, has had some significant education. And, one thing you're going to ask them if they're doing 24-hour urines. That's going to be the creme de la creme. 24-hour urines, not 5-point urine tests. No, not peeing on filter paper. No, 24-hour urines. If they're doing that, they've got quite an education going there and quite a commitment going. But you don't necessarily need that. There's a lot of good providers that they have enough experience to dial you in pretty correctly. But that's your job. Go shopping. Go from one office to another to another. That's a job. That's what you really need. Our book, Happy, Healthy Hormones, can give you a good idea of what you're looking for. Carolyn posts that, and you can download it for no charge, the PDF version. But your job is to go shopping, because I'm suggesting that there is a recipe for you, as there is for everyone, in which you can feel better and get long-term protection.
Doctor shopping, you get with the doctor finally, and then it might be like a little bit of a tweak of this or maybe that. But as you said, we take them the rest of our lives and we feel better. It seems to me that there are actually more and more doctors that are specializing in this, at least from what I'm seeing, and I'm very excited about that. Very. So, yes, well, thank you. Thank you. I mean, if a woman has like really super, well, there are places all over the body that you can actually apply creams or oils, correct? It doesn't have to be in just one place.
There are, but I doubt that that's the issue.
Got it. Okay. All right. Well, thank you. Okay, so this question to me is interesting, and it comes in from a lovely woman. Dr. Rosensweet, can you please explain what receptor sites are? I am reading that we have them all over our body, and this is really confusing to me. Where do the hormones go that we take, and where do they go to work at? Thank you.
It's a good question. And Carolyn, the thing that stands out to me most is, why in the world would a woman have to ask that question? Because here's why. Because women very often are faced with trying to figure this out themselves. And they've got a lot of questions. They're not getting these questions answered. And so they're trying to say, okay, I have to do it myself. And I think I'm taking a little bit of a sidetrack here. And of course, I always love curiosity, and I've dealt with a lot of women over the last 28 years. And there's a certain percentage of these women that are scientifically interested. They do want to know the details. But I think there's another whole host of women that they rather just be able to go to someone who knew what they were doing. Just like me. I mean, I once, as I said on this, I once was so interested in cars that I decided to rebuild an engine when I was in my early 30s. And I did it. And it didn't go more than 7,000 miles. And then from that point on, my job was to find a good mechanic and let them do everything. And then the mechanics would try and explain something to me, and I'd say, no need to explain. I've got a lot to do. I'm just glad I found you. You just do your thing, please. I know that's a little bit of a sidetrack, but I think this is one of the signs of our times, that women are feeling like they're going to have to figure it out themselves. And they're going to have to monitor any treatment that they've got going on, because they cannot necessarily rely on their healthcare provider, no matter how kind they are, to get this right. So I do salute you for that. Now I promise to answer the question. Hormones are, when it comes down to it, they're just these little molecular structures, and they have an effect. And they leave the ovary, for example, and they travel around to your whole body, and they have action on so many different parts of your body. It's outrageous. You think of estrogen female. Well, yeah, it does work on the uterus and the breast, that's for sure, but it works on the arteries and the brain, big time on the brain, and the vagina and the bones. Estrogens, testosterone works on lots of different things as well. Well, how do they do that? Well, molecularly, or when you look under an ultra super duper microscope, you see what happens is the hormones are carried around the bloodstream by these plasma proteins after they leave the ovary, and they travel to every cell in the body. And I'll pretend this is the hormones. Well, they arrive at every cell, they make it through the cell membrane, they make it to the nucleus of the cell. And in order to do their thing, they just can't say, okay, now do what I'm telling you to do. No, in the nucleus of the cell, there are receptor sites that are they are configured to receive certain specific hormones. So the hormone's floating around and it meets up with that receptor site, goes into that receptor site. It's that union, that interaction. Oh, it's about connection and relationship once again on the ultra microscopic level. If you can solve connection on the receptor site level, perhaps you'll be able to solve it on a heart and soul level with the human beings in your life. But that's how it's working. You got these steroid hormones floating around. They make it into this cell nucleus and they interact with the receptor site. They go in there, and that union, that connection, causes the effect. Then the hormone leaves the receptor site, travels around the bloodstream, goes to the liver, where it is metabolized. It undergoes a biochemical change and is excreted. That's how it works. So receptor sites are actually ultra microscopic molecular structures that exist within cells, and they're specific. They're not tremendously specific. I mean, there's estrogen receptor sites. There's two of them, major ones. They're specific for estrogen, but also progesterone will bind to these things. And so there's a whole world inside to understand interaction with receptor sites. But here's the news: you don't have to know anything about them, because it's very unlikely that you got any control over them, with one exception, one important exception. Hormones are not the only thing that can bind to these receptor sites. Something that looks like hormones but aren't hormones, they can bind to the receptor sites. And like in the world of estrogens, it's not only your ovarian estrogens or your compounded bioidentical estrogens that you're taking that bind to the receptor sites. Some other funky molecules can bind to those receptor sites. They're even given a name, xenoestrogens, Xeno, estrogens. And what are these xenoestrogens? They didn't even exist on Earth until the last couple hundred years, when people started dragging the dinosaurs from deep in the earth where they had landed up to the surface in the form of not actual dinosaurs. They brought them to the surface in the form of oil, petroleum. Do you think our planet needs to wean itself off of petroleum products? And what's made out of these petroleum products? Plastics, herbicides, pesticides, chemicals so strong they can kill bugs. Bugs are pretty hardy. You can't just spray fairy dust on them and watch them die. you got to use a very strong chemical. Oops. And they're spraying these herbicides and pesticides on the food that you're eating, unless you're eating organic. That gives you your best shot of not getting these herbicides and pesticides. And it's in the water, it's in the air. There are so many chemicals, there's thousands of them. They've got these horrible names. Well, they're not horrible names, they're just chemical names. And what do the dinosaurs act like in a woman and man's body? They could act like what? Anything. But they don't. They act like xenoestrogens. They can bind to estrogen receptor sites, steroid hormone receptor sites, and then you bunged up the works. There's some women who don't respond well to hormones, and one of the first things we think of is, oh my God, they've had so much toxic exposure that xenoestrogens are occupying these receptor sites. So I went to a conference in Tucson just about a month and a half ago. There was the environmental medicine group. Oh boy, do these people know about toxins and detoxification. We all got to detoxify. Our exposure is so huge. And one of the things we always encourage you to do is clean up your house and get rid of all these chemicals. And what do you use to clean your house? Get it down to diluted clear vinegar and baking soda. Get rid of all the rest of the stuff. Don't spend your money on it. It's poisonous stuff. And you do have to eat organic. And what am I saying here? That there are things that can screw up these receptor sites, and they are doing it rampantly. And this conference was just so detailed, but this has been known for 20, 30 years. Xenoestrogens. Dr. Lindsay Berkson, for example, who shows up on our Facebook Live, and a dear friend of mine and colleague, she's written about this. Devaki, if you're out there, greetings. And it's well known in the functional medicine community. Toxicity. Don't minimize your exposure to poison. Duh. But the problem is this poison's coming in on so many different ways. So you got to educate yourself a little bit, and it gets a lot cheaper to live if you avoid these poisons. You don't have all these chemicals in your house doing this and that. You don't do these exposures, and sometimes it's hard to get rid of these chemicals, but you get rid of them. So receptor sites can be screwed up and made dysfunctional or partially functional by these chemical toxins that we're exposed to. Get rid of the toxins. It's one of the reasons that the menopause provides our pharmacists dispense our hormones not in toxic gels and creams that have toxic potential. These are in certified organic oils, good for your skin. I got sunburned when I was at a conference in Florida. I got majorly sunburned.
You did?
And last night, in the middle of the night, I have a stash of pure oils that we use. And man, I rubbed them all over. My sunburn felt great. So anyway,
I like the stash part.
There's not a lot of things we need to know to really improve our health. And one of them is we got to eat pure food. We got to eat organic food, because the supermarket food has got herbicides and pesticide chemicals on it. Not to mention they're very depleted of nutrients compared to organic food. And we've got to avoid all these household chemicals that disguised in these nice bottles and have these nice advertisements. Improve the smell of your house with this fragrance releaser. They don't reveal that it'll bung up it's got the risk of bunging up your receptor sites. Get rid of all that stuff. Get it down to clear distilled vinegar and baking soda. So detoxification is important. And so you want to understand detoxification, and there are simple measures that you can do to detoxify. is one famous pathologist, Russell Jaffe, said, look, someone can take a radiator and stick it in a closet or their bathroom and heat that radiator up so that room heats up to 104 degrees, and that person's going to sweat. And
Mm-hmm.
that's a real good temperature to release these volatile hydrocarbons, because these dinosaurs in the form of oil and toxic chemicals, or that's what they're called, volatile hydrocarbons, and they will volatilize and they'll come out of your body in your sweat. Or you can purchase a portable sauna. It's $350. You can get an infrared sauna, a little tent that you can that's collapsible and you can store in a closet. But I've got one in my bathroom set up. You go in from time to time, heat up, and these things come bubbling out. Well, they don't come bubbling out, but they come oozing out of your sweat. And sometimes it's important to do that. Coffee enemas. There's lots of things that you need to do to get rid of these chemicals we've acquired, because healing is possible.
Yeah, it is. And that's the good news. That's the positive, wonderful news. Absolutely. Angie writes in, are there toxic ingredients in the patch?
Well, it's not my favorite. They've got absorption enhancers in there. If the only tool I had was the patch, that would be the tool I would use. But it's got estradiol in there. It doesn't have any estriol in there. We're prescribing to women an estrogen that's a combination called Biased. It's got 80% estriol and 20% estradiol. The patches are estradiol only, and they have absorption enhancers in there. So if you read the patch insert, you're going to see some chemicals there. I would like to repeat that if the patch was the only tool I had, I would use it. But it isn't the only tool. You can get pure bioidentical hormones in non-toxic oils.
Because there are carriers and fillers and this and that and all
If
that.
you read the label, you're going to see names of chemicals that you're not going to recognize. They're not a huge exposure, but you do it day in and day out. Like, for example, 18 years ago, the pharmacist shipped a Biased, an estrogen jar, to our office instead of to our patients. And I had been practicing for 10 years and I had never seen a hormone. I just wrote a prescription to the pharmacist, and the patient picks them up at the pharmacy, or the pharmacist ships them to the patient. I had never seen a hormone. I was fascinated. Came in a white cosmetic jar, was sealed. I broke the seal. I wanted to see what a hormone looked like. And out came this strong odor. These are even for compounded bioidentical hormones. Steroid hormones are very poorly soluble. So you have to use strong solvents to get them into solution. So every time you do a click with a toppy click, or you do a syringe, or however you're going to deliver these, you're going to get the same dose every time. You got to get them up in a solution. And we did some research on what kind of solvents were being used. Strong solvents. They have to be strong solvents. They do not dissolve in water. They do not dissolve in weak solvents. You need dinosaur extract of dinosaur.
Hang on, I have some. Let me get it to show you.
I'm being facetious, but
I
it's
know.
the oil. It's petroleum products that are the source of many of these solvents. Extract of dinosaur.
Extract of dinosaur.
And so that's when we invented and got patents on certified organic oils. This is not a solution. It means the woman or the man has to rotate the bottle before usage, about that much, and the mixture works really well. There's no solvents in there. So I did a calculation of how much I had been prescribing these gels that had toxic potential to women for 10 years, and I did some math. And what I learned was a woman was applying plus or minus a quart of this stuff every year to her skin, absorbs for 10, 20, 30 years, 40 years, 50 years. That really adds up. So meanwhile, I'm a functional medicine doc. I'm detoxifying people, but I'm toxifying the women.
Right.
by prescribing a carrier base, and 99% of what's in the jar is base. It's not hormones. There's grams. There's like 80 or 120 grams of hormones in those jars, and I'm sorry, of carrier grams, and there's milligrams of the actual hormone. So,
Thank you for the compliment. You know, Dr. Rosensweet, that is a subject we can go on and on and on and on and on about for like ever, and probably will at some point, for sure.
they're important subjects, yeah.
It's a huge subject, and I won't repeat what the 3 words are that I learned in school, but boy, they are edged in my mind, and I get it. And it's interesting, and pure is good, and what you say is so true, and it's so appreciated. Truly, it is. Antoinette wrote in, have you ever heard of normal thyroid levels needing assistance regulation as a result of taking bioidenticals?
Yes.
Go figure.
That's a good question, Antoinette. That
Excellent.
reveals that you know a lot of detail. I mean, these hormones are so powerful and they're all interrelated. And you adjust one and you better look at the others. And you can affect thyroid hormone dosage levels by giving estrogen and progesterone. And so sometimes we'll reassess thyroid levels after a woman's been on the bioidentical ovarian hormones, and we need to. And I want to talk for a moment, Antoinette, about normal levels. Laboratories all around the world report reference ranges, i.e., normal levels. And they do it through a mathematical statistical trick called they test thousands and thousands of people, and they find who's the median, who's the middle, what's the middle number. And then they do a statistical analysis in which they choose 2 standard deviations beyond that median in both directions. Now, I'm not going to explain what that is, but when you look at a reference range from a laboratory, it's really wide because it's the American laboratory going public that are the cohort that's being studied to develop these reference ranges, and a lot of them not even well. But even if they were only chose really healthy people, you'd still see a wide range because people are so individual. So, for example, there's many ways to assess thyroid levels, and one of them is thyroid stimulating hormone. That's actually a pituitary hormone, and the reference range is 0.5 to 4.5. That's 1 and 2 standard deviations beyond the mean. How laboratory reports it. Well, I want to tell you something. If I see a TSH that's above 1.5, that pituitary gland is trying to stimulate that thyroid, and you could have someone who was actually low functionally in thyroid. So many physicians know how to better interpret these ranges. The last time I looked at the fasting glucose range, I think it was 65 to 99. That would be called normal. Who's got the 65s and the 70s? Young people. And it gradually creeps up there. And when I see a fasting blood glucose of 84 or 86, I'm going, oh, people are losing control here. They got a rising fasting blood glucose here. So what is normal ranges? And so many doctors know this. They'll go, yeah, you got normal range glucose, but 90 is not cutting it. And it's giving me a clue that you're developing insulin resistance, and how you're going to be in 5 years or 10 years. You better curtail that diet of yours. So reference ranges are funny. And thyroid ranges are just like all ranges. So you gotta have an extra You got to be able to apply extra scrutiny to the reference ranges that are provided. And you really want to know what the optimal ranges are. And we've actually done that with the 24-hour urine hormone tests to assess optimal levels of women we're treating in menopause with compounded bioidentical hormones. They went into the medical literature to define optimal range. Don't go lower. You put your bones at risk and your vagina at risk for bone loss and vaginal atrophy. Don't go lower, and don't go higher, or you're going to possibly stimulate breast glandular tissue to proliferate. That's what we're defining as the reference range, not too much and not too little. So as far as thyroid goes, and going back to your question, Antoinette, we use a finer tuned scrutiny of thyroid levels, and we always get the TSH, the free T4, the free T3, and the reverse T3 minimal to assess thyroid levels. And you'll see that, for example, there's a range for free T3 and free T4. And for example, on free T4, if I'm remembering correctly, you see the young people have 1.1 and above. And it's common to see a midlife person have a 0.9 free T4. Well, how's that going for them? You can see a free T4. You see young people, they got a free T3 above 3. What happens when you see a midlife person who's got a free T3 of 2.4? It's in the reference range. It's in the quote normal range. It ain't normal. That person is stressed that thyroid gland, and they probably don't have enough to have optimal function. They're not going to have an illness. So this level of scrutiny needs to be understood. We have a 12-hour training program that's online for professionals. Our longest segment is thyroid. Because there's a complexity to thyroid, and you got to know more than just the reference ranges. But back to your question, Antoinette, that's very perceptive. If someone is on thyroid hormone and they're getting the replenished ovarian hormones, estrogen, testosterone, progesterone, and DHEA, there's many women that you got to recheck those thyroid levels at the 3-month mark, for example, because they could have alterations there. Some of the women will even get symptomatic. So yes, great question. Should be reevaluated after you've been on these ovarian hormones, after you've gotten optimal levels clinically for yourself on thyroid, and you've done 24-hour urine hormone. On ovarian hormones, and you've done 24-hour urines. Reassess those thyroids. They may need tweaking. That's the only thing that's going to happen. It's not going to drive you nuts. It's not going to get you ill, but it is worth fine tuning.
Well, she brings up the point that standard protocol in the biofield is estrogen, progesterone, testosterone, though she's stating that she's never heard much of an emphasis on the use of DHEA until now. She's wondering why that is. Many women have never heard of DHEA. It's true.
And DHEA, it's in a little bit of a gray area. You have to understand that these hormones are related biochemically to one another. And for example, so we don't know if DHEA has direct hormonal action, but it certainly is a prohormone, meaning it occupies an important site in the biochemical processing and conversion of one substance to another. We know that for sure. And think about this, DHEA is the most prevalent, the most abundant steroid hormone in the body. There's more DHEA than there is testosterone and estrogen and progesterone. Gee, do you think maybe it's needed?
I'll get back to you on that.
You measure DHEA. Yeah, thank you, Carolyn. You get back to me.
I'll get back to you on that.
When you measure these hormones, there's more DHEA than there is others, each one of them. So I think it has a role. And in fact, DHEA, if nothing else, In a woman, it'll commonly convert to testosterone.
Mm.
So it can convert to estrogen. We don't have control over what's it going to convert to. But you take DHEA, it can raise your testosterone, it can raise your estrogen. It could have hormonal effects in itself, although that has not been identified. And here's another thing about DHEA. Like every other ovarian hormone, DHEA is also coming out of the adrenals, by the way. Like every other ovarian hormone, your highest levels of DHEA in women and men is when you're 20 plus or minus 2 years. And here's what happens: decline. So by the time the woman's at midlife or the man's at midlife, man, that DHEA is so much lower. I don't recall the last time. I would say in 28 years of testing and treating women in menopause, I've seen decent, not youthful, levels of DHEA in probably 5 patients out of hundreds and hundreds and hundreds. Women midlife, they don't have enough DHEA, so we replenish DHEA. And be careful. You can take DHEA orally, but women do not take more than 15 milligrams a day. Don't be tempted by those things that they put at the doors of big box pharmacies that has 25 milligrams of DHEA there. Don't buy it. 15 milligrams max, because you can overdose on DHEA. This is an accident. This is an FDA pounce waiting to happen.
Yeah.
These women are taking excessive dosages. So women, don't take over 15 milligrams of oral DHEA a day. That'll be safe when you're midlife.
Yeah,
and
thank you.
Be sure you do take DHEA. What do we do? We're working to copy nature to some degree.
Mm-hmm.
So if you get super low on a hormone or a prohormone, we replenish it because we can. And we don't want to give you too much because these things are all so powerful.
Mm-hmm.
So your job is once again the same. Find a provider who knows what proper dosages are.
No,
and
absolutely.
knows how to test you.
Yes. 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 I see. Possibly, I don't know if I should wait to ask this question next time because it's a bit heady, but I'll give this to you and you tell me. May we please explore weight gain? Is this caused by taking hormones?
I think we should save that one.
Right, I'm not even going to
Let's
go
save
on
it to
with
next
that.
time. It's such a crucial question,
I'll
and I
use
want
it
to
as
do it.
number
I want to do it justice. So let's save it and lead off with it on Tuesday.
Okay. I want to acknowledge Jan. Hi, Jan. Good morning. Well, we got through all of our questions. So I don't know if it's going to need a hard stop today. I'm really, really glad that we were able to get through them for sure. Because it's really valuable information. Absolutely. Uh, uh, Back to the DHEA, Dr. Rosensweet. Yeah, and I know you said, pharmacy, this, that, the other. I did walk into a store. There was 50 milligrams, of DHEA. And I'm just wondering why they would give that much in a bottle to a person and think that's okay.
Yeah, because people don't know what they're doing.
Well, yeah, I guess. I didn't.
And DHEA is too strong. It should be prescribed only, in my own personal opinion. But this mistake that people can make, women can take more than 15 milligrams of DHEA a day, and because they can just pick it off the shelf and think maybe, well, this must be okay because it's on a big box shelf.
But maybe they're not taking anything else, and all they're taking is DHEA, and they're taking 50 milligrams of it, and that kind of seems to me like a disaster waiting to happen. Yeah.
Well, it's not a disaster.
Okay.
But it's over the long run, it's not beneficial. You don't want to cause elevations of other hormone levels because you took an excessive amount of DHEA.
Got it.
It's not a disaster, but it's hormones are powerful, and you don't want to take too much of them, or you don't want to have too little of them.
Got it. Good morning, Jen. Jennifer writes in, I don't know if you can answer this or not, but she says, my THE is less than 0.005 with a low normal free T3 and T4. Is that okay?
Say that again.
My TSH is less than 0.005 with a low normal free T3 and T4. Is that okay?
What is the low normal? Did she mention the number on the free T3 and free T4?
No. She said low normal.
Not enough information.
Okay.
It's not, there's something funny going on there.
Okay.
If there was actually a low normal free T3 and free T4, you would not expect to see a TSH that is at the very, very low end of normal. TSH is thyroid stimulating hormone. It comes out of the pituitary gland, and it increases when your brain and your body says, wow, I don't think we got enough free T3 and free T4. We better stimulate that thyroid gland to ramp up production here. So it's an inverse mathematical relationship. The higher the TSH, that's going to come in response to the body reading the thyroid hormones that are circulating are too low. Vice versa. If the TSH is low, there's no need for the pituitary to stimulate the thyroid. That means there's going to be a higher free T3 and free T4. It's an inverse relationship. It's a little bit tricky to understand. Well, she has a low TSH and she's got a low normal free T3 and free T4. Something unusual. She needs an expert to sort that out.
Yeah, and she says, my doctor thinks I'm overdosed on thyroid.
Well, that would be the first inclination, because when you see a very low TSH, now I won't call, we very often see a very low TSH, like 0.005. And we're perfectly content with that if clinically someone's okay and the free T3 and the free T4 is okay, and there's no elevation in the reverse T3. Because if you're overdosed, your body's going to protect you by dismobilizing some of that thyroid hormone. It's going to change the chemical configuration of your T3, and you're going to get something called reverse T3 to elevate. So we use all of these parameters to assess what's going on, and not enough work has been done here. So, Carolyn, would you also hold this one for next time? Because understanding thyroid is very important.
Oh, yes.
Because midlife, we've strained our bodies quite a bit through dysfunctional response to stress and overdoing things. And we tire these glands out, and they don't function as well. They function enough for us to live, but a thyroid gland takes quite a hit, gets overused. And so midlife, you got a lot of functionally low thyroid. And this woman's got a situation that needs to be understood better. And she needs like, we need to know, when was that blood drawn? But it doesn't make sense that she has a low TSH, and it's not a concerning low TSH. It's not concerning at all. And she's got a low free T3 and a free T4. Something's not correct. So someone who understands thyroid needs to sort that out. I'm not trying to scare anybody. It's not a disease in most instances. It's just a thyroid depletion and imbalance that's not understood. Need more information. I'm not going to say there's an overdose, especially when you got a low free T3 and free T4, but it depends when you drew the blood. So I know that doesn't adequately answer, but we need more investigation there.
Okay.
Were you able to hear me? Because it looks like you're a little frozen there.
I am not frozen. I'm just mystified by this answer. It's great. And I will indeed take many of these, and yeah, we'll get into that on Tuesday for sure.
And see if you can contact that woman and see if you can get a little more information.
Yes,
Like
I'm in touch with her.
when was
Yeah.
the blood drawn in relationship to when she took her last thyroid dose, and what thyroid dosages is she on?
Okay.
What type and what dosage? That would help. She
Okay.
needs more information, but she needs a reverse T3. I can tell you right now. Sometimes the pituitary gland is just failing, and you got low numbers because it's just failing to do something. Because with a low free T3 and free T4, you'd expect a high TSH or slightly elevated.
Yeah.
I know that's not an adequate explanation, but let's pick it up again because it's a great question.
It is, and more are coming in, and boy, yeah. So it's good. It's good because I know what I'm going to be writing for sure. Yeah, excellent. Um, do you have more time, or
I don't know. I'm
Oh,
definitely time to go.
all right.
So I
Well,
wish everybody well, and I'll see you all next Tuesday.
indeed, so will I.
Indeed.
Have a great weekend, everybody. Thanks for being here. You always thank you, Dr. Rosensweet, and we'll see everybody later.
All right. Good to see you, Karen.
Always good to see you.
Yeah. Bye bye.